Hi everyone, thanks for joining. We're going to get started now. Just a reminder, 30 minutes, one question, one follow-up. Today we have Dr. Williams and Dr. Yaffe here, so I'll turn it over to them to get started.
Okay, well, thank you, and good afternoon. And to start off with, I'm going to hand things over to Dr. Yaffe to go over some highlights and some numbers for the time since the last teleconference or media conference on Thursday. So over to you, Dr. Yaffe.
Thanks a lot. Good afternoon, everyone. I hope you had a good weekend, stayed home, and stayed safe. Since the last update on Thursday, Ontario has reported an additional 12,054 new cases of COVID-19, and sadly, another 244 people have lost their lives to COVID-19. Our healthcare system continues to be strained, with elevated numbers of people in hospital. At this point, 1,571 people in hospital with COVID-19 or under investigation for it, including almost 400 people in the ICU. And while today Ontario is reporting our lowest number of daily new cases since January 1st, 2,578 cases, our 7-day average is still very high at 3,035. I will also note that the number of tests processed yesterday, 40,301, was at its lowest since January 5th, which may partially explain the lower numbers we've seen today. In terms of outbreaks, we're reporting 31 new outbreaks today, and that is slightly lower than what we reported last Monday. When calculating the total number of new outbreaks over the last 7 days, today that number is 280 as compared to 1 week ago when we saw 330 new outbreaks reported in 1 week. So while we're seeing some improvements, we need to keep monitoring to determine whether these and other key indicators continue in the right direction. We are now reporting a total of 15 cases of the UK variant, or B117, COVID-19 in Ontario. The most recent case reported resides in London, Ontario, and has no history of travel outside of Canada. We do expect more cases to be identified in the weeks to follow, as there is evidence now of community transmission. This is concerning to all of us, especially as the data indicates that this variant may be spread about 56% more easily than other variants. The best way, again, to protect yourself and the community from further spread is to follow public health advice and adhere to the stay-at-home order. That means not making trips out of your home unless you have to, and not having contact with people who are not part of your household. I would now like to turn over to Dr. Williams for some additional comments.
So thank you, Dr. Yaffe, and I would certainly echo those comments, and I'll have a few to make on that. So I think the good part is that as we look at the numbers that we've seen and understanding where we were a week ago, excuse me, we see that the modelers were saying if we stayed on our track, even the so-called 3% growth, we would be at somewhere around 4,500, closer to 5,000. We would, if we're on the 5%, we would be definitely over 5,000 at this time. We have not seen that. We got close with some reporting systems issues. We plateaued around the mid 3,000, and this last week we've been down below that in the low 3,000s. And as Dr. Yaffe noted, today we were at 2,500, but this is the weekend, with lower number of tests being done. But in the past number of weeks, all during the so-called holiday season and after, even when our numbers did go down a bit on the weekends, the percent positivity went up quite extensively. This time it did not go up, and our percent positivity has also been dropping. I take that as a sign that Ontarians are doing what we're doing. We're making success, we're making headway. These are only just a few numbers. We look at everything we can to see the positive sign of that, to say, you're doing a good job, keep at it. And those that are still having trouble, you need to focus, get back to the task of doing that, and decrease the spread. Because as Dr. Yaffe said, even some places outside, we're seeing some pop up of the UK variants where people say, I don't recall any travel history or contact. But as the modeler said, it starts off very small and it starts passing person to person. And so the person who gets it may be 2 or 3 out, and you want to track that back. So it's harder to track in that way. So we want to be vigilant. We want to be careful. It's showing signs that we're having some success in that. Our outbreaks are down. There's some early indication that even some of the homes we've done some of our vaccination in, that some of those may be abating a bit. It's early. We want to see how we do on that. So our vaccine program is another very critical initiative in this one. But we can't do that alone. We have to still do our case contact management. We still have to do our physical distancing, hand hygiene, masking in public spaces wherever you can't maintain your distancing. Keep to your household, stay at home, as we said, because we see people doing that. I still see people out doing their walk, either with them and their family or spouse or partner, or with their dog. So that's good. Especially if the weather was fairly decent on the weekend, that you would continue to do that. So we have some of the positive indications that we are making some headway at flattening the curve. We would sort of move ourselves down to the 1% growth level, maybe heading down to 0%, as in staying at the 1%, but early days. Don't want to conclude that too quickly. Let's see what happens over the next number of days into this week ahead. The vaccine, we're going to have to be a bit more judicious on our use of it and rolling it out. General Hillier and the team have been working with the postponement of some of the delivery orders, reductions of the Pfizer product in particular is the only one, with a 20% reduction at this time in the week coming up, and then a 80% reduction in the next shipment. As the company goes through a refurbishing of their plant, they're hoping to increase their production capacity from 1.3 billion doses to 2 billion. So there is some sense that that's going to increase the ability to put out even more in the future. We have to go with that. We have to work with that, and we're trying to keep to our priorities in there to make sure that we're dealing with our priority list. That means some have to wait a little bit, and we're going to keep monitoring that situation as we move ahead. So, still stay home. We haven't completed a week yet. Some of the effects we're seeing from the reductions from the time over the week, the holidays, we're seeing now some of those effects of those lockdown periods. Now we're going to add to the stay at home, because we wouldn't expect to see any effect of that further enhancement in the first few days since we've done it. It only hasn't been a week until Wednesday. And so we'll have to see as we go past that, through 10, 11, 12 days past that, see if there's further even enhancement, because we'd like to not only plateau our numbers, as we've seen, drive them down even further and see if we can get really down lower and get our hospital admissions down, get our ICU numbers down, and come out of that very concerning zone that I know the minister and the premier and others have been talking about, and leaders in the hospital sector are most concerned. We're making headway. Let's keep at it. Say well done. And we'll keep giving you announcements and updates as we go along, as much as our data shows us and as up to date as we can. So that's where we're at. And as Dr. Yaffe said, keep all those things in place. We're doing well. Keep at it. So I'm going to hand over to media now for questions.
We'll go to the phone lines. Just a reminder, 1 question, 1 follow-up. Over to the first question, please.
First question comes from Rob Ferguson at the Toronto Star. Please go ahead.
Hi, doctors. I just wanted to ask a little bit more about the UK variant. I heard a report on National Public Radio in the States on Saturday that the Centers for Disease Control have said they see low level of community transmission of the UK variant across the country, and they expect it to be the dominant strain in the United States by March. So where are we on that? I know last week you said you don't want it to become dominant, but what do you foresee here?
So, Dr. Yaffe, I'll let you start off, because you've been conferring on this one, and I can add a few comments after.
Sure. Well, it's hard to predict. There are a number of variants, actually, of concern right now for COVID-19. And we're working very closely with the Public Health Ontario Laboratory, which is doing more and more genotyping and sequencing to identify these variants, working with the National Lab and other labs across the country. So, as I said, we've identified 15 cases of the UK variant, B117. Undoubtedly, there are more that we don't know about. we have not at this point been able to identify any of the other two that are of concern at this point, the South African variant and the Brazilian variant, but we're looking. So unfortunately, I believe all three of these have the mutation that confers increased transmissibility. And so the fact that we have at least a small number of cases of the UK variant now that have no history of travel is concerning. They must have acquired it, obviously, in the community. There are other cases we don't know about. And yes, this just causes us to redouble our efforts to everybody stay at home, do all the basic measures, and the case and contact follow-up becomes even more critical. So it could very well become the predominant strain. We don't know. We're going to do our best to avoid that, obviously. But it is concerning, and that's why the labs are doing more and more genomic sequencing and reporting out on these variants.
Mm-hmm. And I would add, Rob, that United States, and this is a compliment to Ontarians, where we've seen a very large part of our population doing all the measures we've talked about. So in the past, while we've concerned about some not, we have a lot of people doing that. Surprising data that I would say to add proof of that is that this time of the year, we would be reporting daily 400 to 500 or 600 new cases of influenza A in our province. And I got the data from last week, and we had 1 case of A and 1 case of B. And we have a total of less than 15 for the whole season. Never seen that low a number. And I think that's because people are doing all the protection measures. They're distancing, they're wearing a mask. Some people have said, usually I get 2 or 3 colds a year. This has been one of my best ones yet. And it shows you that people are taking care. Which strain would I like to have dominant? I don't want any strain dominant, let alone. So the protection that we put in place for our other strains also protects against the UK variant. You just have to be careful. As I said, it transmits much more rapidly. And so what you might have got away with, say, a 10 to 15-minute face-to-face conversation with people unmasked, with the other ones, you're not going to get away with that with the UK variant. So you're going to have to be a lot more stringent and careful in there. If we do that, I don't see it becoming one. And of course, countries that have not been able to maintain proper protocols are having to deal with it. And it quite easily could become the dominant strain or other new variants as they come forward, because that's what coronavirus is typically known to do.
Follow-up?
Yes, I just wondered if we could get some more detail on how much more screening there is. I think it was Dr. Yaffe last week said trying to come up with new testing protocols to catch more of this. So is it random screening? How many tests are being screened for this?
I believe, I'll start, and then I'm sure you'll be able to add something. But I believe that they're testing any case of COVID-19 that has a travel history outside the country or any connection to a travel history. They're testing any case where there has been a super spreading event, a concerning rapid spread in a population or in a group, and they're doing random testing as well. So last time I spoke to Dr. Allen, the chief microbiologist at the Public Health Ontario lab, they had already tested, I believe, 500 or 600 specimens. That's just their lab. There are multiple labs across the country doing this testing, so probably thousands have been tested at this point. And they're trying to come up with some organized way of reporting out on this as well. So definitely travel is the highest risk at this point. And unfortunately, some of the cases haven't had travel at this point.
Yeah, and I would say, as I said, a couple of press conferences before, the lab all the way through the whole first and second wave has been doing genomic sequencing on sampling of lab tests. Before the UK variant came on, they'd done approximately 6,000 to 8,000. So we keep looking for that. And one of the advantages we have here in Ontario is our public health laboratory can do the sequencing and identifying the UK variant. Other provinces and territories have to rely on the National Medical Laboratory in Winnipeg, but we have that sophistication here and expertise with Dr. Vanessa Allen and the rest of their team to undertake that. So we'll keep monitoring, keep looking, and keep sampling and identify high-risk situations and do the testing accordingly.
Next question.
Next question comes from John McGrath at TVO. Please go ahead.
Good afternoon. The U.S. FDA has warned that certain COVID tests by a company, I believe Curative, have a high propensity to give false negatives. I'm wondering if you know if those types of tests are being used in Ontario, or if any of the tests being used in Ontario have been evaluated for that kind of problem of high false negatives.
Right, and that's always been a key question of ours when we're using these point-of-care tests or rapid antigen testing methods, and there's other new ones coming out, that our public health laboratory does parallel testing of that. And while our PCR test, our main one, has a very high sensitivity and specificity, so very, very limited, low rate, if at all, of false negative or false positive. But that is a complicated test. It takes time to do it. But that's been our gold standard. The other tests we've rated, and some of the rapid antigen tests, do have up to a 30% false negative rating. And therefore then, I think if you're going to use that, especially for more for screening testing, not for diagnostic, that one would need to do what we call sequential testing to limit the amount of false negativity, or in a way to confirm the negative as another confirmed negative. So there's various ways. So all the time, our public health laboratory is monitoring those new ones coming out and attesting their sensitivity and specificity. That means ruling in and ruling out their ability to identify false positives and false negatives in that matter. So we have some concerns, but we want to use those tests for the right thing. And so some are very valuable for doing surveillance in that, and you can always confirm them by PCR. But if you're going to do like sequential rapid antigen tests, you can diminish the false negative rate very considerably.
Follow-up?
This is on a slightly different topic, and I guess it's probably something to consider for the future. But given the vaccine rollout plan that we saw last week, seniors, those over 60 or 65, are going to be among the first vaccinated, while young children are going to be among the last to be vaccinated. So I'm wondering what the current guidance is on whether grandparents should babysit their grandchildren, for example.
So being in that category, I can tell you it's very clear, is that we shouldn't be babysitting the grandchildren in that, and have not been, which is unfortunate. So that's just the reality of it at this time, with especially our stay-at-home orders. It's virtual at this time. So I think some of the vaccine companies are trying to look at seeing if their vaccines are amenable to be used in younger people under the age of, first it was 18, then 16, and they're going to keep doing some clinical trials to assess that, and new strains coming out, new vaccine trials and that to look at that. So we don't have a child vaccine yet that has been approved for a notice of compliance by any authority at this time. So right now we're going to have to do our priority groups. We have not made any statements to say if people have had 2 vaccines, what kind of protection that affords them. We still have to get a lot of people done with 2 vaccines. We're, as I call, immunized versus vaccinated. We have about 20,000, over 20,000 now in Ontario, so that's a good achievement in that. And then we're watching this on a go-forward basis and monitoring and assessing. But right now, no, those over 65, especially those over 65, 70, unfortunately at this time you can't do that unless you're actually already in part of the household, like a grandparent living in with the family all along. Then I guess they know that the situation there, which we've allowed before to happen, but that's a unique situation that has been in place all along. So be patient, be waiting, keep doing the video conferencing, and I think the parents also want help in babysitting, but that's another whole question. So we hope to be able to keep these numbers going down and move into a better range. But right now, we're in tight vigilance and to maintain that distancing at this time.
Next question.
Next question comes from Colin DeMello at CTV News. Please go ahead.
Hi, good afternoon, doctors. I had a question about the critical care triage document that all hospitals are now preparing for. I'm curious about how close hospitals are to actually triggering critical care triage. I mean, is that a realistic outcome of the current situation, or is that, completely out of the realm of possibilities as you see it right now?
Well, I think always in these things is to be prepared. And I think what they're doing to say, in a worst case scenario, in a moderate to severe case scenario, in a low case scenario, different ones, because you don't want to think about it in the heat of it. You want to lay these things out ahead of time. So I think they've done that with the hope saying, we hope to never have to use this. And I think they're moving it around to look at, because you want to have all the different ones weigh in with their commentary and saying, I agree with that part, I don't agree with that part. Because it's hard to get a group of doctors in a room together to agree on everything. And it's better if you socialize that and get the input and the collective knowledge and wisdom in a worst case scenario. Hoping it's not something you're going to pull off the shelf. You hope to never do that. But it's better to think about it ahead of time rather than the heat of the action. So that's just one of the many things that are being done throughout the whole sector to prepare for, as the modeling has shown us, different scenarios that we're going to have to face as now our ICU beds are over that 400. We talked about today, they dipped down a little bit. They're still over that 400 level. We'd like to get them down, back down to below the 200 level, ideally below the 150 level. That's where we like to target. That's where the modeler said we could get back to then doing all the other procedures at the same time. That's a target to head for. I think we can get there, especially if we keep driving the way we're going now. But it's uncertain. We're precarious, that term again. We're plateauing, but it doesn't mean we can't jump up again, because places like UK and others plateaued and then went up very rapidly when the UK variant took off writ large through their countries. So we can't let our guard down.
Follow up?
Thank you. The document outlines random selection for a critical care bed if multiple patients within a hospital meet the criteria for a critical care bed. Can you explain how that process would work, and why would people be picked at random for critical care if multiple patients meet the criteria?
I must say I haven't seen the context of the random, so I really can't comment on that. Usually there is a criteria, but so I'd be reluctant to comment on that aspect at this time, because I know they're just developing it, and so I haven't had the privilege to look at it. It's not really typically in my scope to review what critical care physicians will do in that one. I know our ministry is, so I really can't comment on the details of that at this time.
Last question.
Last question comes from Randy Rath at CHCH TV. Please go ahead.
Hi, doctors. I'm wondering, I know this may be somewhere out in the future, but what do we need to see the numbers down to so that we can end the current state of lockdown?
So we haven't got a definite number. I'll give you the ballpark based on the modeling data, which it's fairly mathematical. They said if you get below 150 ICU beds, COVID patients in ICU beds, that starts to get you back down to where all the hospitals can start to do their other elective procedures. Not so elective because some are urgent, because all those ICU beds are always heavily utilized in that, and trying to get our backlog of surgery dealt with, because if we don't do that, there are some other consequences of COVID and mortality and morbidity indirectly related, and we're concerned about that. We want to get that down. If you do that, knowing the different numbers and percents that usually get admitted to a hospital, our current rates in the second wave, and how many of those end up in ICU, you'll get a general sense that you got to get below somewhere around or below 1,000 new cases a day. Back where we were in those days, it seemed a long time ago. That was actually right back in, I think, October and November. So it wasn't that far back. I'm just going to look at my data sheet here just to be sure. We were at 1,700 in December even. And so we went up fairly rapidly. The last time we were close to around 1,000 was in end of October. So not that far back. It is achievable. We can get back there. So that's what I'm saying is a general ballpark. I can't say exactly, knowing that it'll lag, even if you get down to 1,000, because they tend to lag 2 or 3 weeks later, going to admissions into ICU, et cetera. And the ones in ICU stay for a period of time. They don't just get handled in a day or two. So that's a general ballpark of what I'm trying to see where we can get back to. Excuse me, the end of October. Again, that was only a couple of months ago, so 3 months ago. So we can get back there, I believe.
Follow up, and this is the last question.
Yeah, I have another question with regards to Niagara. The health officials down there are wondering why they haven't been declared a hot spot that it has ramifications when it comes to vaccine distribution, that type of thing. And they have one of the highest per capita rates of COVID infection. It's higher than Toronto's. How do you decide what is a hot spot and what isn't?
So the term hotspot, before we went into the stay-at-home and, of course, the lockdown on Boxing Day, we had our 5 places that were already well up in the numbers there. And at that time, Niagara was not in that category. Niagara had only recently gone up, and we've seen some places that were not even in orange, like one of the southern ones, like Lambton, going from there and bypass even Niagara. That's because of a clustered outbreak and that, and they're slowly bringing that back down. And so the various metrics that we would use to call a hot zone is a combination, like Niagara is alluding to, their cases per 100,000. And they only started going up over the last 2 weeks and we're going to see can their numbers come back down again. They're dealing with some aspects around long-term care outbreaks, some workplace outbreaks. Is it indicative of wide community spread? It's not a clear metric in that sense. We work it out with them. So I know where the numbers are at the moment. We see they're actually dipping a little bit too at this time. So I'm hopeful they can keep bringing that down, as well as Windsor-Essex, which was the highest by far and far out, supersedes Niagara in that, and then they're coming down. But our big ones like Toronto, Peel, and York, and Hamilton are plateauing, some of them, and they're starting to come down a bit. So all looking very positive, and we hope also Niagara will be able to turn that and bring that back down as well.
Thanks, everyone.